like to introduce Marisa Aguilar. She's the practice manager of the expanded mobile crisis outreach team at Integral Care. Since joining Integral Care 7 years ago, Ms. Aguilar has contributed to their mobile crisis services and crisis intervention training for first responders. She has played a key role in bridging the gap between behavioral health services, emergency medical services, and criminal justice. Ms. Colleen McCollough is a program manager at Integral Care. She manages clinicians within the 911 call center, a first-in-class and nationally recognized project that integrates mental health clinicians within the local emergency response system. Ms. McCollough holds a Master of Social Work degree from the University of Texas at Austin, and for more than 10 years prior to her work at Integral Care, she provided direct mental health care to consumers in crisis in inpatient and outpatient settings. Lieutenant Kenneth Murphy has over 29 years of law enforcement experience and has worked in various positions, including executive lieutenant to the office of chief, watch commander, detective, SWAT team, and firearms instructor. And for the last 5 years, Lieutenant Murphy has served as the Emergency Communications Division Director for the Austin Police Department, where he leads a team of over 200 staff. Prior to his career in law enforcement, Lieutenant Murphy served in the United States Air Force. And this is mental health services as an option when calling 911.
Thank you so much for that introduction, and good afternoon, everybody. We're very excited to be here today to give you information about our project where we have integrated our crisis clinicians into Austin, Texas Emergency Communications Center. We're going to start off by giving a little bit of background on our crisis services in Austin, Texas through the local mental health authority. We then will move into where we're at to date with integration into the 911 call center, and then give you information and strategies about how to do integration into the 911 call center to really support getting individuals in crisis the right care at the right time, some lessons learned and some outcomes and data that we've collected since the inception of our project. So a little bit of background on our community and the crisis services that we have. Colleen and I work for Integral Care, which is the local mental health authority of Travis County in Austin, Texas. We have a very robust crisis service system within our city. We have a 24/7 crisis helpline, and we've had a MCOT team, or a mobile crisis outreach team, that began in 2006 that receives all of their referrals from our community 24/7 crisis helpline. The goal of the MCOT model is to serve individuals that are experiencing barriers to accessing services. So very concretely, individuals that might be experiencing challenges related to transportation to get to services, financial, or lack of family or friend support to get them connected to the services that they might need. We look to ensure that we are providing least restrictive level of care options when we're providing our clinical assessments, and all of our services are community-based services. Our goal is to ensure that not only are we providing least restrictive options during our first clinical intervention, but that we can provide up to 90 days of service so that we can provide case management, living skills training, crisis treatment planning, and then we also have mobile medical providers who can go out with us into the community to help with crisis stabilization if that's needed. Our goal is really to prevent the overuse and misuse of very restrictive settings for individuals in crisis. So specifically looking at, from law enforcement referrals, individuals that might be incarcerated, individuals that might be placed on a peace officer's emergency detention or involuntary commitment, and from our EMS partners, individuals that might be transported or admitted to an emergency room setting. So that team has been running since 2006. In 2013, we expanded our MCOT team to really focus on ensuring that we were filling gaps within that system. What we learned by looking at data was that the majority of time people were calling 911, and they weren't necessarily calling our community helpline 472 help to access a MCOT team to come out and help them during their crisis episode. So we expanded our MCOT team. We still have our original team from 2006 who is deployed out from our crisis helpline, but now have an additional team that is able to work specifically with first responders when they identify that someone is in a mental health crisis. They get on the radio, they request our assistance, and an MCOT team is deployed out to provide assistance. We, since that time, have continued our expansion and evolving into ensuring that we are providing individuals with the right care at the right time. And our team has integrated now into the 911 call center so that we have the ability to provide services more upstream in the process and really focus on ensuring that we are reducing any need for a more restrictive setting or more restrictive intervention for someone when it is not needed. So that integration into our 911 call center started in 2019, where we have a team of our expanded mobile crisis outreach team clinicians on the call center floor, available to take calls when someone at 911 is experiencing a mental health crisis. Our program is the Call Center Diversion Program. Again, it focuses on diverting appropriate mental health-related calls received by Austin's Police Department call takers to one of our call center clinicians. We call them C3s. Our goal is to engage the caller in addressing the mental health services so that we can ensure that they are accessing mental health treatment as opposed to getting any type of involvement in the criminal justice system if it's not necessary. We are an add-on service to the 911 operators who are answering the call and doing the initial triage to ensure that we still have the opportunity to deploy emergency services if there's imminent risk of harm to that person during their crisis. The call center clinicians provide a clinical screening that focuses on risk to that individual. Our goal is really to provide de-escalation of crisis. We do safety planning, and we have an opportunity to deploy out our own expanded mobile crisis outreach team to go provide a clinical assessment, all with the goal of ensuring that we're getting the most appropriate resource out and diverting police response when it is not necessary. So this graphic just gives you a little bit about where we have been, what I've talked about, and where we are currently at right now. Again, our project started in 2019, and we had a very narrow focus on calls that we wanted to identify at the 911 call center that would be appropriate for transfer to our 911 clinicians. We wanted to ensure that not only our clinicians, but also the 911 call takers were very comfortable and confident in those calls that were coming in, triaging and assigning appropriate priority so that we ensured that we were getting people the right care at the right time. We have since expanded our call types that we have been able to assist with. And the most exciting piece that we have been able to implement happened this year in February, where we've added mental health services as an option when someone calls 911. So we've spoken with a lot of different cities throughout the nation. We've even spoken with people in Canada. And we know that we are the first in the nation to add mental health services as an option. This has really provided an opportunity for individuals at the start of the 911 call to self-identify that there's a mental health crisis that they might be experiencing, and or if they're calling about a loved one or someone that they're working with that is going through a mental health crisis. I think it's really important to note that it's a collaboration through the local mental health authority with Austin Police Department, and how we've been able to kind of work together and really cultivate this project and the success that we have seen in getting police diverted for calls when it's not appropriate or there's not a public safety or imminent risk of harm to that individual. So I'm going to go ahead and pass it over to Lieutenant Murphy, who's going to talk about the call types that we identified at the start of the project, so that you can see the types of calls that have been diverted and transferred over to our call center clinicians.
Good afternoon, everyone. Happy to be here. Quick question. How many are aware, and I don't mean this in a negative connotation, but are aware of how emergency communication centers work? Have been to a emergency communication center before? Okay, a few. And it's important to point out when we're talking about this program, communication centers all across the country are very different. In Austin, we have a fairly large communication center. We have separate 911 operators from police dispatchers. Most smaller emergency communication centers have one person who answers 911 calls and dispatch, and sometimes they dispatch for multiple agencies. So a program, in looking at developing a program like this, it's not a one-size-fits-all. You have to really tailor the program to your city, your county, your area, and what will work best for your area. Okay, when we were looking at what was important, or the call types that we wanted to be able to transfer to our C3s, really the most important one was someone not attempting or actively attempting to hurt themselves or someone else, and where there was no threat of imminent risk to the person or anyone else. So these are calls appropriate for transfer to the C3, calls experiencing a mental health crisis and not actively attempting to hurt themselves or someone else. Callers indicating there is a verbal dispute or disturbance only, and there is a mental health component. Callers requesting police due to psychosis or an altered mental state. Parents requesting police due to a child behavioral issues. Now this one's a little bit different. This doesn't have to involve mental health. But and I know we have some law enforcement officials in here, think back when we were on the streets, which calls did you really not like going to? Those calls where the parents called up and said, my kid's misbehaving, can you come and take care of him? I'm not their parent, right? So law enforcement officers hated going to those calls. So we said, well, you know, if there's a parent-child issue, why not let a clinician handle it, right? And provide resources and referral services to those parents instead of sending officers. And tell you what, our officers love it. They love not having to go to those calls anymore. Callers with repeat callers with a known mental health history. We have several of those in Austin. I don't know if you're familiar with your areas, if you have several of those folks in your areas as well, but we have quite a few of them. So we try to send those callers to the clinicians, again, to follow up on referral services. Callers experiencing a mental health crisis and requesting a mental health officer. In Austin, we have crisis intervention officers who are trained in the 80 hours of TCOLD crisis intervention. We're in the process of training all of our officers to hold the 80-hour crisis intervention officer training. Right now, every officer exits the academy with 40 hours of mental health training. And hopefully within the next 12 to 18 months, we will have all of our officers trained for the 80 hours, up to the 80-hour course. And another transfer is a caller experiencing mental health crisis and the call does not meet the transfer criteria, or if the 911 operator believes the clinician could assist in de-escalation prior to the officer's arrival. So the clinicians in our center have three primary functions. The first one is true diversion, meaning we don't send police officers, we don't send EMS, we don't send anyone except for possibly our clinician teams in the field, which are 2 clinicians who respond. The second one is consult. So when a 911 operator has someone on the phone and they believe there may be a mental health issue or they're not sure and they need some assistance, they will conference in a clinician who will then ask them questions via our CAD system so the operator can ask those questions and find out the answers to them to determine whether this can go to the clinicians or we need to send it to an officer. And then the third one is de-escalation. When we have a first-party caller on the phone who's suffering a mental health crisis and officers are en route, we will conference in the clinician to talk to the person on the phone in an attempt to de-escalate the situation prior to officers' arrival, which benefits not only the person calling, but also the officers. And we've had several success stories. One recently in August where we had a gentleman calling who had a gun to his head, and we transferred it to the clinician. The clinician was able to talk the person down, he put the gun down, unloaded the gun, and by that time we had a hostage negotiator on scene. We conferenced in the hostage negotiator, and they were able to talk the person out of the hotel room, and he was provided the treatment he needed. So that was just one of several de-escalation stories we have that have been successful. We also have second-party callers, those callers who call in and say, I'm worried about my daughter, I'm worried about my son or my friend. I'm seeing, posts on Facebook or on Twitter, and so we'll transfer those callers to the clinician so the clinician can get some more information and determine whether they can send the field teams or they need to send an officer. Oops. Okay, now let's talk about calls we cannot send to the clinicians. Individuals in possession of firearms or knives or weapons of any type. Again, the idea is safety. That's the overriding theme of all this. We have to be safe. We have to protect the clinicians. We're not going to, and not only clinicians, but the callers, who are not going to send our clinicians into a dangerous situation. An individual under the influence of alcohol or drugs to the extent requiring medical intervention or exhibiting violent behavior. If someone's been drinking or they're under the influence of drugs, but they can hold a meaningful conversation, we'll still transfer those folks to the clinician to see if the clinicians can possibly assist them without sending officers. An individual threatening or at an imminent risk of hurting themselves or others or killing themselves or someone else. When an individual has committed a crime, specifically family violence, we must send officers. And what we call our hotshot calls, those calls involving an imminent risk of threat to life or property. And some priority one calls with the exception of our check welfare calls. But as long as they don't meet any of the other disqualifiers. Again, we talk about how the C3s, the clinicians, can support our first responders and our 911 operators. The C3s, again, are a source for support during the call to the 911 operators. They provide resources to better prepare the caller for handling future mental health-related crises, de-escalation, which we've already talked about, and providing initial or additional information to 911 operators so the operators can add the information into our CAD system and the officers are aware of this information as they're responding to the scene. One of the lessons learned was when we initially started this program, we did not have our clinicians built into our 911 system and our computer-aided dispatch system. They were standalone. We would transfer calls to an administrative line. That didn't work out so well because we had a lot of hangups. People in crisis do not like to be placed on hold, and they hung up on us. So we soon learned we needed to teach our clinicians how to operate our CAD system, computer-aided dispatch system, and our 911 system. So we trained them up, and now they're in our Solacom system, which is our 911 system, and our CAD, and there's a seamless transfer of the call. The clinicians can see the information the 911 operators are entering into the CAD call, and the clinicians have the ability to enter information into the CAD call for the 911 operators and for the police officers who are responding to the scene, which has been very beneficial for us. The other thing we did with our 911 operators is through Integral Care. Marisa and her team trained all of our 911 operators and police dispatchers and leads in mental health first aid. So that was very important. That was a very important step in bringing the two groups together. Our 911 operators receiving more training than they normally do through the TCOL mandated courses, through mental health first aid, and then again, teaching the clinicians how to operate the CAD system. When we're talking about CAD, it's important to understand, or any type of computer-aided dispatch system, it's important to understand you need to identify, if you're going to develop a program like this, data. What type of data are you going to collect, and what type of data can you collect through your CAD system? So what we did, we created a mental health field in our CAD system. So our 911 operators, when they ask the question, and they ask it on almost every call, if the caller is aware, if the person they're calling about is suffering from a mental health crisis, or they believe they are. And so the operators can go in and in a drop-down in CAD check, no, there's no mental health crisis. Yes, there's a mental health crisis. And when we did not have our clinicians working 24/7, they had the option of checking, yes, we could have transferred this to the clinician. However, the clinician was unavailable. And now, with the addition of the fourth option of mental health services, when someone calls 911, we have a mental health services box they can check in there as well. So we can collect all this data, which really shows how beneficial this program is. Okay, I think I will turn it over to Marisa now. Thank you very much for your time. That's Colleen, not Marisa. My bad. Sorry.
All right, thank you. So my name is Colleen McCollough. I am the program manager at the 911 call center. So we did talk a little bit about the timeline, just to show you what this really looks like. We took our first call in December of 2019. And at that time, we did not have a separate team. We were all clinicians within the EMCOT team, which Marisa spoke about, the Emergency Mobile Crisis Outreach Team. And we had started with a limited time frame. So at the time, we were starting at 40 hours a week. And of course, I remember when I took the first call, I was actually the person to do it. We were on a little phone. I had something akin to a traffic light over me that I would flip on red if I was on the phone, and green if I was available, and the call takers would actually stand up and look over their cubicles to see if I was available. So we've come a long way. And of course, when COVID occurred, we had to scale back a little bit. And at that time, we worked from 2 p.m. to 10 p.m., Monday through Friday. And that was actually, in a strange way, it was something that I was able to do. And that's really when the relationships developed and we really got to work. So in June of 2020, that's when we did get the computer-aided dispatch, or CAD, and we added some additional call types. In February of 2021, Marisa spoke about this already, but that is when we added the fourth option of, so now when you call 911, it says, are you calling police, fire, EMS, or mental health? Which, to me, I think it's really exciting as a mental health practitioner to see people self-identify. I think it's very empowering, and it does a lot to reduce stigma when somebody can verbalize that I need a mental health assistance. It's also important to note, though, if they say police and they still meet criteria, we are still available. So that is not the only deciding factor for whether a person gets our services. In May of 2021, we were our own independent team from EMCOT and started with one person. I believe I was first hired November of 2020, and we were able to fill enough positions that we could be 24/7 at the call. And we also added additional call types, including, which I think was really exciting. So a lot of the focus had been on capturing calls at the start of the crisis, and we heard feedback from officers that, hey, I'm still getting calls that I feel like C3 could help with. Like, I really want to see if you all could do something. So what we have now is introduce a process where officers can request that C3s, the clinicians, review a call before the officer goes out. And that has resulted in many diversions and police being canceled or different kind of referrals, which is really exciting as well. So for us, and for me in particular, actually, Marisa, do you want to talk a little bit about the first four?
Yes, just to kind of go over some of the key strategies that got us started, I think it's very important to just highlight that we have some great programs already in the state of Texas that had been doing this work and integration prior to when we started in 2019. So Lieutenant Murphy and I, prior to us starting, went to do site visits, specifically here in Texas, in Houston and Dallas, Texas. Visited their teams and their call centers to really learn what they had been doing, get lessons learned, any strategies they had for building our project. And that was very helpful for us when we implemented it here in Austin, Texas. I think that that's a really good thing to do, and just know that every city is going to be different. You're going to have unique needs specifically for your city, and what will your call center look like in integration. And we found going to the site visits was very useful to bring some things back and then develop what was going to work for us in Travis County. And then, of course, the building of the relationships with our first responder partners. We had had a long-standing relationship with Austin Police Department, EMS, our Travis County Sheriff's Office, because of the work that we were doing with the expanded mobile crisis outreach team. And that really helped kind of bridge what the relationships look like integrating into the 911 call center, knowing that we sometimes have different perspectives and coming from a different lens, working with first responder systems and then as the local mental health authority, but ensuring that we were all working towards the same goal of getting people the right care at the right time and ensuring that we were getting the right resource out to somebody in a crisis. That's been very important since we started our relationship, responding to calls in the community, and has carried us through to integration into the 911 call center and working with the call takers, Lieutenant Murphy staff.
Mm-hmm. Yeah, and I think being at the call center itself has proven to be extremely beneficial in that we can build those relationships. I think it's important as the clinicians coming in and as the team coming in. I imagine if I'm a call taker that's been working in this field for years and I see people sitting in seats that I normally like to sit in, are they going to be helpful or hinder my process? And is this something that's going to take away or add to the work I do? And for me, it's still important that we are clinicians that are there in support, that we're a team, and that we work hard to facilitate those relationships. And there's a lot of adjustment and listening to feedback that we've done. And that has also really made some great changes in why we've been able to expand and do the work we can do. The other key strategy is a data collection. People, when they give you money, they want to know, what are you doing with the money we're giving you? Are you actually having results? So there was the data that was expected, which is just how many calls you're taking, how much are you diverting? And then there was the additional stuff that maybe is not requested. So for me, it was really important as I was creating a call log and creating this data set that I was listening to the local leaders. I was listening to the community. I was, going on podcasts, listening to podcasts, I should say, and understanding what is the goal that Austin, Texas is wanting from this, and making sure I then collect data that demonstrates that. So one thing that I added that was not requested was when we transfer back to 911, what was the reason? So because we had that data, we're able to say, right now we have 80-ish% diversion from 911. When people use us from police response, 80% we're able to divert. But of that 20%, a big majority is people still want police. And, people have rights to choose the kind of response they get. And that's a very important thing for us to communicate then with our funders and community advocates. And that's a great place for us to educate the community as well. So when we talk about lessons learned, technology, as you've heard, is a big one. And I can say we went from maybe about 30% of the people dropping the calls when we would transfer by phone to really almost eliminating that completely. And the training itself with the staff has been very important. So we building relationship with call takers, training call takers, but also training the staff. We've trained them all in counseling for access to lethal means, safety planning. We are going to be working with hostage negotiators. And in addition to that training, that piece is so important because recruiting has been a big lesson. This is a 24-hour team, and not a lot of clinicians are used to working 24 hours. This is a very different kind of ask. So when I was creating a schedule, I really worked with EMS, and I worked with different people, including Lieutenant Murphy, about what does staffing 24/7 look like. And when I changed the posting from 4 days to 10 hours to 3 days, 12-hour shifts, I got a lot more postings. And I also found that the kind of people that were the most successful were people that had traits where they could be calm under pressure, where they had empathy, and they were really good and detail-oriented and flexible. So to me, we could train in all of the suicide assessment best practices, but if they didn't have those initial skills, they probably weren't going to do as well. And as you can see, we transferred, this data is a little bit off because we go back and rectified some of that. So it's actually 4,500 numbers of calls transferred, and we are diverting 81%. And as you can see here, these are the outcomes. Again, that call disconnected 9%. That was when we were primarily, they were disconnecting when we were on the phone. We dispatch our own clinicians about 13% of the time. We also found, being there, that a lot of the people who call are already connected to our integral care team, and we can then provide that information to the treatment teams themselves that this person's calling and this is what they're saying, what kind of support can you provide? And we also link to community resources, so we are also handling a lot in-house, which I think is also a really exciting change as well for emergency. You know, when you think about emergency, you call 911 and you immediately go out. That's quite a cost. So to be able to have clinicians stationed there and to provide that assistance, service, and it's not only is it beneficial to the person, but it's beneficial to the community in many ways. But I think that's all we got.
Do we have time for a few questions?
That's all we got.
And thank you all. At this time, we have time for just one question or so until the next speakers line up and get ready. Okay, Roy? Ms. Gutierrez, can you speak up?
Yes, I heard. So the integration into the 911 call center is funded by the city of Austin. And there was a bullet point on the side. We do have a interlocal and then a memorandum of understanding with the city of Austin for our project as well.
We do have a question from one of our virtual attendees, and it's how is Integral Care collecting feedback from the community on how the 911 call center, MCOT, is working?
I'm sorry, what was the last part of the question?
On how the 911 call center, MCOT, is working?
So the way that we gather feedback primarily is from a community behavioral health criminal justice advisory committee that is comprised of stakeholders and community advocates that are working within behavioral health as well as the criminal justice system. We provide quarterly presentations on data, both from the integral care side plus from Austin Police Department, and then elicit any feedback from primarily from that group, but other avenues as well.
Okay, I have just one. When you started this early, did you identify any peak hours or peak days for high use for, say, a county that wanted to try and start this initially without going whole hog for 24 hours?
Yes, we did. So we actually looked at data from Austin Police Department and the calls that they, the frequency distribution for calls that they coded as a mental health call. The primary hours, if I'm remembering correctly, were the afternoon to 12 a.m. And so when we started our project, Colleen actually took the first calls, and she was working 40 hours a week, 2 p.m. to 10 p.m. to try and cover the highest volume of calls that APD was receiving and coding as mental health.